Hello and welcome to the Two View, the cutting-edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. My name is Mike Sharma. I'm a practicing emergency medicine and urgent care PA in the Dallas, Texas area and an adjunct professor of PA studies.
And hi, Mike. I'm Martha Roberts. I'm an emergency medicine NP and assistant professor in Northern California.
Great to see you, Martha. Love the new look. Like I mentioned, the highlights are really kind of bringing things out on you. It's a good summer look for you.
Yeah, like I said, I don't want to be boring, and I felt like brown hair was boring for me. But in the winter, I'll find blonde boring. So, whatever.
You could never be boring, Martha. Oh, I had such a great time at the American Academy of PA's National Conference in Denver. My talk went awesome. I met new people. I reunited with old friends, some going all the way back to PA school. And the Academy of PAs in Legal Medicine made some really big strides forward as an organization. I did, however, leave my phone charger behind. So if anyone finds it, please hook a podcast host up and shoot me an email.
Yeah, just like the last piece of cake. Once you leave that on the counter, you'll never see it again. So, we're going to be recording today the show here. It's about noon-ish on a Tuesday. And for those of you that are listening, we want to remind you for all of our podcasts, time zones don't matter. You can listen anywhere, anytime. And we just wanted to emulate the job of emergency and urgent care clinicians dutifully. So, one thing that you may not be aware of that our show notes have direct links to read the literature we use to support this show, which we encourage you to take a look at. That also includes links to our prior shows, which we try to keep as evergreen as possible. Although we do give our personal opinions on things here and there, we want to ensure you that we have quality reading for you. And in my past life, I just wanted to mention, I was an audio engineer, believe it or not. So music is kind of my thing. We didn't actually have a crazy theme song for our show, but in my mind, I made one. But that makes me want to jump right into our first segment.
Let's jump right in. It's time for our first segment, the Wet Read, where Martha and I get 60 quick seconds or so to talk about something that caught our eye.
All right. So let's get international for our first segment. We've talked on multiple previous podcasts about various ways to treat our patients' pain. A randomized control trial out of Thailand, published in April in the International Journal of Emergency Medicine, further provides evidence that music therapy significantly reduced the average pain scores in emergency department patients. We included music therapy in the study to look at, such as non-pharmacological methods of pain control, and we also have included in our past episodes the king of pain himself, Sergei Motov. If you go way back, I don't know, say episode 1 in January of 2021, we'll link those notes on our website at twoview.fireside.fm. That's the number 2, the word view, .fireside.fm. Sorry, I forgot it for a second there.
It's been a while since you've been on the website, apparently. It's still there. It's good.
Yes, yes, yes. So again, back to the music. So music therapy is not just about listening to the latest jam from Taylor Swift, Sabrina Carpenter, and oldies but goodies from The Clash, but can include singing familiar, comforting songs together for reminiscence or emotional support, guided meditation accompanied by soothing music to encourage relaxation, writing original music or lyrics that share your story, very cathartic, talking about messages found in lyrics and what we can learn from them. A great discussion at parties. Absolutely love that. Not just for healthcare. Playing drums or other percussion instruments to release tension or stress. And I even had a patient beat a pillow once to the tune of Dirty Diana, and that's a story for another time. But in this study, it was a single center trial of patients with stable vital signs, non-surgical etiologies of pain. Further, the study suggested that anxiety scores were lower and ED service quality scores were higher in the music therapy trial arm. And this approach worked better for non-traumatic etiologies of pain over trauma-related pain.
You're not going to necessarily use music therapy or this modality for every single patient in pain, but it's nice to have a robust tool belt full of tools that you can pull out when appropriate. You have something, a backup plan if your plan A or B don't work like you want them to. Especially in a patient who's going to be kicking it in the ED for a while. Maybe they're waiting on an MRI. Maybe they're boarding while waiting on their inpatient room to open up. Maybe turning on some soothing music or even consulting a music therapist, if you're fortunate to have one on staff, is an option you could consider. Well, switching gears from hot tunes to hot temps, we have already had our first day over 100 degrees Fahrenheit in the Dallas area. It's time to consider heat injuries again. The Society of Critical Care Medicine, or SCCM, just dropped new guidelines for the treatment of heat stroke earlier this year. Heat stroke is called that because, just like, quote, regular stroke, patients can suffer permanent deficits or even die from heat stroke. The key symptom of heat stroke is altered mental status, and the critical intervention is cold water immersion. I'm talking dunking the entire patient's body in cold water. This understandably requires some degree of preparation for that immersion. A tub of some sort, heck, to get morbid, even a body bag can hold a person and fluid inside of it without leaking. So that is an option. If you are involved in any sort of activities this summer in which people can suffer from heat stress, it's important that you prepare, that you or whoever is in medical control of the event has some sort of way of doing this on site at the point of heat injury. The faster the person is cooled, the less damage is done to their body. So this may mean not transporting a very sick patient immediately to the ER. If you can cool them better on scene, then the ambulance can cool them on the way. What I like about SECM's guidelines, that I've never seen before, is that they have a chart that shows just how inadequate other traditional cooling methods are compared to cold water immersion. Martha and I have been in the game not for a super long time, but long enough to recall being instructed, like, you want to put those ice packs in the groin or the armpits, or you want to mist and fan and mist and fan and then fan and then mist them again. But even after 30 minutes, these traditional interventions change a person's body temperature by about one half of a degree Celsius or less after even 30 minutes of misting and fanning and misting and fanning. So inadequate when somebody has heat stroke.
When does my misting and fanning begin today? I'm just curious.
You just got to pick, like, are you going to fan first or are you going to mist first? You have to just make a decision and go for it.
I feel like I should fan a little bit to get the hair out of the way and then mist, double mist, fan again. But
Fair.
Anyway, beyond guidelines, the absolute best graphic educating us about heat stroke was put out a few years ago by the Raw Medicine podcast, which I'm not sure is still around, but the graphic lives on. And we'll have that in our guidelines, in our notes, everything listed in our show notes on heat injury treatment. So check us out again on our website at 2view.fireside.fm. That's the number 2, view.fireside.fm. All right. So, we have some listener mail, Mike. It's exciting. We have some listener mail.
That's great. It's from a nurse practitioner, right? Do you want to go ahead and read that one?
Okay. Here we go. Yes, I do. Let me start this one. Who's it from?
It's Julie.
Okay. So Julie, she asks, I am an FNP, board certifies. She's great, wonderful. I have been on, so she's an acute care hospitalist for 3 years, and she's interested in transitioning to emergency medicine. She says, I need more training, knowledge, and confidence in EM. I'm not interested. She says, I'm sorry. I am not interested and I am unable. Oh, okay. This is different. She's not interested and unable to return to school for a fellowship for this. Totally understandable. Can you guys advise on ways I could achieve this training and knowledge? I'm not sure if it's best just to attend conferences, although she has been eyeing the EM conference in Las Vegas in November. Should I do an EM boot camp? Should I take an ENP certification exam? And if so, what are the prerequisites that you guys know of? Whew. Okay, Julie, this is a lot.
It's a lot.
I'm going to try to answer everything as briefly as possible. But I like this question because there's no doubt in my mind that I love when clinicians want to transfer to other areas of medicine or nursing. That's the beauty of being a nurse practitioner or PA. I am excited to hear your interest in EM. There are a couple of ways to transition, and some of them include just shadowing someone for a couple of days. I know it's kind of hard to get those gigs, but you can try. I try, like for all my students, at least to give them some experience in the ED first. You might not like it, you got to give it a full chance with someone that can show you all the ropes. In addition, I think it's important to audit courses or sit in a course to learn the actual books and paper. I mean, that's important. Go and check out many universities or they have critical care and urgent care courses. They have procedural courses, and you could potentially get a book and, get your classroom knowledge from that. There's also some really great references that I highly suggest you just open up while you make your transition. If procedures are your thing, I recommend Roberts and Hedges, Clinical Procedures in Emergency Medicine and Acute Care, or any of the tried and true current publications, specifically the Lang publication, Emergency Medicine. And then, of course, Rosen's Emergency Medicine is also quite useful. This may sound kind of nerdy, but if you're a reader, start with the airway chapter and read one a week. And then take a deep dive into anything you need more help with. Then I would attend a conference to reinforce those core concepts and build on clinical pearls. And some of the top apps right now are, right in your pocket. You can get them on your phone. UpToDate, Epocrates, Pepid, and any of the EMRA resources. And MRAP, still love the MRAP. One thing I did want to just mention, Mike, because there's a question here about the ENP certification exam and the prerequisites. So as I've talked about on prior shows, you cannot take that exam unless you have an FNP degree. So, unless you have an FNP degree. You cannot take it if you have an ACNP or sole pediatric degree. So basically, it looks like you are a board certified FNP, Julie, so you would qualify for the exam. And if you go on their website, you can get some of their resources. But for someone like me, that's an acute care NP, and then I have 2 additional masters in peds, I can't sit for that exam. But I think if you try some of these other things first, besides just sitting for an exam, you might get a little more out of it.
Some other options, you mentioned the EMRA resources. I literally just yesterday recommended to an NP student that was with me. There's a lot of these. They're symptom-focused smart books from EMRA, the Emergency Medicine Residents Association, that are very good because I think one of the first things that people struggle with is developing a differential diagnosis. Like somebody comes in with a headache, right? Okay, it's not just like, is this a migraine or not? Is this a bleed or not? What are all the different things that could cause a headache? And then how do you further, rank order them in terms of likelihood? That's what any sort of emergency medicine point of care resource can help you with. And like EMRA is a good one. I believe there's a 5-minute clinical, what's it called? 5-minute clinical consult?
Yes.
Is another one, right? That's a good, just the facts at point of care. How do I get through this particular patient right in front of me? Of course, Julie, you mentioned the EM boot camp. The original EM boot camp this year will be November 5th through 8th in Las Vegas, Nevada. I think it's going to be the lovely Paris Casino. Is that right? We have that for sure.
We have so many trips to Las Vegas, I can't even keep them straight, to be honest.
They're going to run together. I'm almost certain it's Paris, but it's one of those on the strip in the middle of everything. Great hotel, great food, and things to see while you're there. That's going to be November 5th through the 8th, and there are some pre-course days as well, whether you want to hang out with Michael Gucher's practitioner and get a really in-depth course on pharmacology for an EM clinician. He can do that with you. There's also emergency ultrasound and other emergency procedures as well. So that's something you can go to live if you want to wait until November. If you just can't wait, jump on the CCME website, www.ccme.org, and you can buy the streaming version of that or any of the courses we have. One I want to highlight, we're just We are pumping them out right now. It's really impressive. Like I feel like every other month I turn around and there's like a new offering. I can't decide which one I want to experience next. But the one that really caught my eye recently was the Bounce Backs course. This Bounce Backs course, it's based on a book series by emergency physician Mike Weinstock, really experienced educator and author of this Bounce Back series. And these are basically the scariest books you will ever read in your life if you are in medicine. It talks about patients who looked to some degree benign and were discharged home and then came back, bounced back with more serious presentation of their disease. And he has a version for EM, for peds, for crit care, and then one that kind of gets more into the medical and legal side of things with depositions and stuff. And it's that course, the medical and legal version of the book, that he has a partnership with Dr. Kevin Clower, one of our alumna, our faculty on the original emergency medicine boot camp. They kind of go back and forth about these cases. I'm really excited to hear them rap about it live. So those are all potential options. You can find all those courses at www.ccme.org. And lastly, which I think would be a good topic for a different day, is you could also look into some sort of an emergency medicine fellowship through some sort of a hospital or other organization. Lots of pros and cons, too many to go into right now, frankly. That deserves its own episode segment.
Yeah, agreed. Really good stuff. Yeah, Kevin Clower, Weinstock, they're just love them so much. I was just reviewing the medical and legal case reviews that they had listed. Case number one, a 39-year-old woman with multiple complaints, coughing during cold and flu season. That already sounds like, oh God, we're missing something. Case number two, a 42-year-old fireman with shoulder pain
Oh
when
no.
a lifeline becomes a noose. Oh boy. Okay. So yeah, you get the idea. These are really wonderful topics to discuss. Scary and indeed, but take a look and you have a chance.
Okay, time for our next segment, I believe.
Yes, time for our next segment. This is our dry scan where we penetrate a little bit deeper into two other topics. So, I want you to try and remember what you were doing back in March 2011. Mike, what were you doing back then?
I had just graduated from PA school less than a year prior. My wife was about to deliver our third daughter, and I was going to have to deploy to Afghanistan a few weeks after she delivered. So I think I was basically just trying to avoid crapping my pants every single day. It was a pretty heady time, March 2011.
Yeah, most people, we tend to try to avoid pooping in the pants, but 2011 was a year for going back to school for me. I did two additional masters in pediatrics, and that was actually the time when I took a deep dive myself in the books. I wasn't quite sure what I wanted to do with my ACMP degree, and I wanted to do a lot more peds. So I went back to school. And the text that saved me was actually the 5-minute consult
Oh,
pediatric emergency medicine book, by the way. I lived by that text and the Braslow tape and PALS course. Those were all things I reviewed frequently.
nice.
But this was also the last time the Infectious Disease Society of America, or IDSA, published clinical practice guidelines for the treatment of acute and uncomplicated cystitis and pyelonephritis in women. Guidelines that were actually completed in 2010, over decades ago. When guidelines were old enough to get a learner's permit, it's time for new guidelines. So thankfully, updated guidelines are currently in the development at the IDSA. If you're going by the existing guidelines for the treatment of pyelonephritis, here's what you'll get. Fluoroquinolones and Bactrim are the first-line treatments as long as local resistance patterns support the use of these antibiotics. And oral beta-lactam agents are less effective than other available agents for the treatment of pyelonephritis. This includes cephalosporins like cephalexin, cefdinir, etc., which are very commonly prescribed drugs for pyelonephritis in 2025. And further complicating things in this decade are growing concerns about fluoroquinolone side effects and increased resistance of urinary tract infections to both fluoroquinolones and Bactrim.
Yep.
As a friend of the podcast and friend in my life, Ken Milne would say guidelines are just that, guidelines. They're not godlines. guidelines is how he says it. Especially when guidelines are relatively old, it's important to take a look at them in the light of other information we have here. Get off that train if it's not going in the right direction. In this case, local antibiograms that can tell you resistance patterns in your area and more recent literature. And speaking of the literature, let's talk about the copy ED trial. Or is it pronounced copied? How's it pronounced?
I was gonna say there's a dash, copy ed. So that's what I think the dash is intentional.
Yeah, okay. Sometimes I feel like I'm not in the cool club if I mispronounce one of the studies wrong. What was the big one? Like there was an airway one where I kept saying it wrong and they're like, "Oh, you are such a loser."
Oh no,
Um, but hey, hopefully this is we'll call it the copy ED
I think
trial.
so. Yeah.
Yeah. Also known as the cephalosporin in outpatient pyelonephritis in the emergency department, hence the acronym
Mm.
trial. And this was published in the Annals of Emergency Medicine in March 2025, so very recent. And this was a multi-center retrospective observational trial of over 800 adults comparing patients in one cohort who got a cephalosporin for treatment of pyelonephritis, two patients in a second cohort who got a so-called IDSA guideline endorsed antibiotic like a fluoroquinolone or Bactrim for the treatment of pyelonephritis. And the primary outcome of the study was treatment failure at 14 days as
Yeah, 14 days if they needed like more antibiotics, if their symptoms came back, if they returned to the ED, that was considered treatment failure.
yes. Okay, so they further define that in the paper. And again, this was a bit of a lengthy one, so you can take a look. And after adjusting for potential confounders, the author's conclusion was that oral cephalosporins were associated with similar treatment failure rates against pyelonephritis as fluoroquinolones or Bactrim, and the most common cephalosporin used was the humble cephalexin, with ceftonir coming in right behind it. Cefuroxime and cefpodoxime were much less frequently used on patients included in that study. It might be understandable to further conclude that maybe despite what IDSA said back in 2010, that certain oral beta-lactam agents aren't less effective in 2025 than other available drugs against pyelonephritis.
Yeah, this gives us some nice cover because, even though we do our best to treat patients who look like they can go home with pyelonephritis, with an oral agent, there's always a chance they get sicker. You do the exact right thing for these patients and they get sicker regardless of what you do. And God forbid you give them a cephalosporin and they get sicker and maybe they get really sick. And then someone says, well, I looked at these guidelines and the guidelines say that oral cephalosporins aren't as good. How dare you? Why would you give that? As opposed to what the guidelines suggest. And so this is a nice way that you can at least point to something to say, hey, guidelines are one thing, but you have to look at evidence as a whole. If the authors can be believed, this is the first multi-center trial assessing the efficacy of treating pyelonephritis in patients being discharged from an ED with cephalosporins, which is wild considering how common of a practice that is, sending somebody home on cephalosporins. We do that all the time for patients with pyelo these days. And the fact that this is kind of the first one that's multi-center in our patient population is a really interesting, number one. And number two, it's great that we can kind of like point our finger towards this. We can kind of tap the sign, as they say, and say, cephalosporins are okay to treat patients with if we're discharging them. There are other organizations that have put out reviews and guidelines covering similar, UTI topics in the past 5 years. JAMA, the Journal of the American Medical Association, AAFP, the American Academy of Family Physicians, have both put out their takes on UTI, but I like this study because it is our patient population, the patient being discharged from the ED. There is a public commenting period on new IDSA guidelines. It just closed in March 2025, so I'm hoping to see some new goodness from IDSA in the next year or so on this topic. Maybe it'll be ready at the time I give my talk on urology stuff in November for the big boot camp conference. That'd be really nice.
Yeah, see, here you say I always say IDSA. I mean, what is it? Tomato, tomato.
It's IDSA, IDSA. Yeah, I
Why
think
can't
you
I
could.
just say IDSA? I've been saying that for 20 years.
I think you totally can, and no one would fault you for it. I just like trying out some new stuff once in a while. Yeah. Well, switching gears to a different kind of infectious disease, I remember when the biggest things I had to worry about catching from a mosquito were like malaria when I was in Iraq and like maybe dengue fever on my honeymoon or something to the Caribbean. Then it was like, okay, West Nile virus, Zika, chikungunya. It's enough to make you want to stay indoors forever. It's time to talk about a re-emerging viral illness. Let's talk about the Oropouche virus. Partially because it's fun to say Oropouche, but also because cases of Oropouche virus infection are really surging in endemic areas of Latin America and the Caribbean. The highest number of cases are in Brazil, Peru, and Cuba. But as we've learned time and time again over the past few years, viruses do not care about national borders. This disease is also known as OroV, but why would you say OroV when you can say
Or
Oropouche?
Pouche.
Oropouche. Oropouche virus is also transmitted by the midges, which are technically small flies, and mosquitoes. Now, there's a couple reasons why this virus is a big deal. About 5% of patients, not a small amount, 5% is a lot, can develop hemorrhagic manifestations. So, nosebleeds, bleeding from the gums, bleeding from the rectum, heavy vaginal bleeding, even petechia, or they may get neuroinvasive disease like meningitis or encephalitis. There have also been concerns expressed about vertical transmission from a pregnant woman to the baby in the womb, with some case reports of fetal death and even things like microcephaly and other congenital abnormalities in women who have been infected with Oropouche. Further, one study suggested that Oropouche virus DNA can be found in semen for 2 months after an infection, so there's even the possibility of sexual transmission of this condition. This sounds bizarre, right? But the first case of someone acquiring Zika virus in the US was by sexual transmission. And that happened right here in Dallas, Texas. We get Ebola, we get sexually transmitted Zika, we get all the things here in Dallas. Incubation time is relatively short, usually 1 or 2 weeks after being in the endemic area. The CDC in a health alert network notice recommended that we as clinicians consider Oropouche virus infection in a patient who has been in an area with documented or suspected Oropouche virus circulation. Again, we're talking Brazil, Peru, or Cuba within 2 weeks of initial symptom onset, and the patient has the following. Here are the symptoms of Oropouche: abrupt onset of reported fever, headache, and either like body aches, joint aches, eye pain, or photophobia, and signs of neuroinvasive disease. So again, abrupt onset of fever and headache, and one of those other things, joint or muscle aches, eye stuff, brain stuff. And they don't have respiratory symptoms, because like right away you could totally see somebody labeling somebody with Oropouche virus as, quote, flu-like symptoms. Oh, they got like fever and they got body aches and kind of like they're kind of not feeling very well. But if I don't hear about a cough, I don't want to hear about flu-like symptoms. I'm hearing about fever and headache. That could be a lot of things. So we should be more worried, according to CDC, if this patient with abrupt sign of symptoms does not have cough or congestion. Further, if the patient has tested for other possible diseases as negative, in particular dengue fever, we mentioned that earlier, very similar in presentation to Oropouche, but especially if you've got somebody with these symptoms, you've ran up the flagpole and they test negative for COVID, for flu, for dengue, for RSV, what have you. If you have strong suspicion of Oropouche virus based on the patient's clinical features and that history of travel, don't wait for negative testing for those infections. Kind of start the process, but early contact your local health department. That's basically the only way you're going to get access to tests for Oropouche. They are right now only with the state health departments and the federal CDC. So, don't wait until you've gone through 2 weeks of testing and still, nothing has popped up. Let them know early. Start the process of reaching out for these tests early, because that probably will take some time to get these tests back from the state or from the CDC.
Yeah, I thought it was important that we should mention how to test for this. Don't feel bad when you don't know how to test for something. I can't remember what we test for everything. I mean, is it PCR? Is it, cerebral spinal fluid? Like, what are we doing? So specifically for this, you can do a PCR test, or you can do cerebral spinal fluid. You could also, I mean, I'm not necessarily going to LP people for this, depending on how sick they are. If they have some kind of encephalitis, maybe. But again, don't feel bad about not knowing what to do, and give a call to the lab, or, as you said, the state-run health departments for further clarification. And as you mentioned, it does look a lot like dengue fever. So rule out dengue virus infection in these travelers, like we just mentioned, because they look so similar. Both infections, both of them, consider avoiding aspirin and NSAIDs because of potential hemorrhagic complications. Stick to acetaminophen for fever and discomfort.
Well, lastly, there's our oral contrast segment where we get into all the nooks and crannies of a topic. And I wanted to talk about discharging patients. My favorite vitamin, vitamin D for discharge. These people are going home out of your care, and you are basically telling the world that, hey, this person's safe. They don't need any more tests. They don't need any more treatment. They don't need to stay in the hospital or need surgery. They are going to go home, and they're at least safe to observe themselves at home. And so this is a very dangerous event, honestly, discharging a patient. There are, especially when you've had a patient who you've had over the course of several hours, maybe have had multiple rounds of tests, vital signs have gone up, vital signs have gone down. It's really important that you make sure that you have really dotted your I's, crossed your T's on these patients, and that not only did you do everything you needed to do for the patient, but you've also communicated well and you've documented appropriately, so that eventually when you get a patient who has a bad outcome that was not expected based on their ED course, they can at least look at you and look at your documentation and say, well, at least when this patient was in front of Martha and in front of Mike, that the patient was okay to go home. So we're just going to quickly kind of like run through a couple of general areas of your care and documentation. And I'll start off with a segment, and then Martha's going to kind of opine kind of off the cuff on things she thinks about with these segments, and we'll kind of flip back and forth. And then Martha has a real nice treat for you at the end of this that I think is really exciting. She had a great idea. So
it's that last piece of cake. I have that for you.
Very good. You saved it for the listener. That's so nice of you.
Come get it.
First one is history and physical. It all starts with history and physical, right? So I include part of that abnormal vital signs. If the patient had at any point abnormal vital signs, it's important that you note it. There's usually a checkbox in there, which is fine. You can just click the box. But I think further beyond clicking the box that you reviewed vital signs, I think you should to some degree explain why it's okay that the vital signs were abnormal. Maybe they were anxious or in pain, or that you at least don't suspect some sort of hemodynamic instability or sepsis, that you at least like molded over these abnormal vital signs and you document that you molded over. Okay. And then if they're abnormal, you repeat vital signs before they're discharged. And then, of course, any concerns the patient brought up, whether it was to you, or when they first checked in at that computer in your waiting room, or during the triage nurses discussion, any concerns they brought up, that you have somehow addressed those concerns. And maybe you're clarifying concerns, right? Like just because someone says, oh, I'm short of breath to the triage nurse, if you talk to them and they're like, oh, I just have nasal congestion, I'm not actually short of breath, then you can say the patient clarified that short of breath, he perceives shortness of breath as the nasal congestion. He actually denied, or she denied, dyspnea. Of course, any sort of pertinent history and exam, positives and negatives for these concerns should be documented. I think the negatives are as important as the positives. Hey, the patient didn't have petechiae and purpura. The patient didn't have increased work of respiration. The patient didn't have swelling and redness to a leg, stuff like that. Martha, any thoughts about just broad history and physical things you want to make sure are locked in tight for your patient before you let them out of your sight?
Yeah, I think going through their medical history, like the past medical history, to ensure that you didn't miss something, because a lot of times patients, when I populate their note or ask them questions, none of that is in there. And then when I go to maybe look at my note later and sign it and put in their actual history of 103 things. Um, yeah, they did have a history of PE. Why didn't they tell me that? Like, come on. I wanted to consider that. So yeah, I think you covered that pretty well. And the vital signs, when patients are on meth, they come in, they're all methed out and their heart rates are like 130 and they calm down a little bit. And then I reassess them. Like I don't just look for a number. I go listen to their heart with my
Hmm.
stethoscope, which by the way, so few people do these days. I can't even tell you. I shouldn't even go off, but like you better be listening to your patient with a stethoscope if you do a physical exam. So please, please continue to do that and redo it. Don't, or you could check a radial pulse, whatever. But patients will remember that. And also remember in your documentation that patients, if they have Epic or some other patient portal, they can read your entire note. Everything that you said in your note is visible to them. Just FYI.
Yeah.
Yeah. So, speaking of that, the diagnostics and decision making, patients can see their test results before you even know about it. So that's
Right.
why they're like, I'm leaving. My chest x ray was read as normal. Goodbye. So, fine. Quickly do your best to get patients out of there in a timely manner, of course, but we all know how difficult that can be. But diagnostics and decision making, review all the diagnostics that you ordered. And if you order chest x rays, don't just read the report. You could look at the chest x ray. They missed a huge hiatal hernia on a chest x-ray. Now, I know they're not always easy to see, but this guy's diaphragm was messed up. There's no comment on it whatsoever. And when you look at the lateral, I was like, holy cow, how can they just like not comment on that? So that explained a lot of this epigastric pain. You need to open up your images. And of course, document any abnormalities, explain their significance, and then direct follow up. We've talked about how, when we worked with Greg Henry at copying the test result, printing it out, highlighting it, handing it to the patient, saying, it's not your emergency today, but I need you to follow up with this with your doctor, yada, yada. And then adequately, you've considered your differential diagnosis even in a non acute setting, adequately ruling out life, limb, organ threats. That's important. And appropriately documenting communication you've had with any staff, consultants, or the patient's family while they're there with their complaint. I also want to make sure that you document that the patient declined any of those testings. So, we do share decision making about CT imaging for assaults all the time.
Hmm.
I really want to document that I had a broken nose after this assault. And sure, we can if you want. But even if I do find it today, if that's really something we want to further investigate with a CT, we're probably not going to do anything about it. Like you can go back and forth, and every situation can be different with assaults. But if it's really becoming a concerning issue, I think that you should just CT the patient. Honestly, I know that's not my favorite thing to do. It's very rare that we get that, but some patients are extremely adamant about having tests for a reason. I'm not saying I order them because a patient made me do it. It means I considered it and it's possible they have that injury. Is it likely? I don't know, but it's not something they can't follow up with in the next couple of days and we could watch it, is what I'm saying. But, at the
Hmm.
end of the day, they may end up getting the CT. So I do have these conversations with patients. I don't let them boss me around, but we do make shared decision making. So write all that stuff down in a short, more abbreviated version than I just told you. And then, of course, document any reasonable attempts to have an alternative plan. Like I said, this patient has a primary care doctor. They've already seen, actually, this is a patient recently. They've already seen plastic surgery in the last year for something else. I'm going to have them follow up with plastic surgery in the next 48 hours, and they can decide if imaging
Totally.
is necessary, which is totally fine. And if you're really concerned about an open nasal fracture, you can put them on antibiotics, fine, which is still debatable in the literature, but
Hmm.
that's also fine. And then, of course, I always suggest documenting and assessing the patient's their capacity when you're going over this information with them. Like, were they able to respond back to you, say, thank you for that, I will do that, or yes, I have a doctor and I'll take it to them, the results or my issue. And so, yeah, I would make sure with diagnostics you do a lot, if not all of those things.
I think what you mentioned was really important, and I didn't even consider this aspect of it. But so there's the patient declining tests you wanted to order. And then the flip side of it is patients making a fist and saying, I really want a CT scan for my non-displaced broken nose or nose injury today. It's like, that's a lot of rads for relatively little
Yeah.
trauma with no clinical need for that. But at the same time, like, okay, there was some trauma. You kind of like bumped your face on something, like, and so you could talk about how you discuss the risks and benefits and alternatives of a CT scan, considering the patient's, low energy mechanism of injury. Patient was insistent upon this, and you decided to get the CT scan. That
Yeah.
like the patient was so adamant about it, and there, as much as of course there is a harm for CT radiation, it's not acutely harmful, right? Like the harm is kind of like pushed down the road for a few decades, for better or for worse. And so when someone is just so adamant about it and it's not completely outside of the realm of discussion, I think it's worth sometimes ordering some of these exams. And you talk about how I wouldn't necessarily have done it myself, but the patient really wanted it. So, hey, we rolled with it. And if there's a downside to the exam later on, look, the patient really wanted it. And we discussed how it wasn't necessary, but the patient really wanted it. I was just trying to help out my patient here. And I'm sorry that there was a bad outcome from that was unforeseen.
Yeah. Well, these cases, assaults and motor vehicle crashes are so difficult because, of course, patients want to know, was this caused by this thing that wasn't my fault? Like,
Mm,
I want to know. And then, of course, like, the only way to really know is to do the test. And I say that if you really want to know, we can do the test. But clinically, you don't have any. I use generic terms, say to them, you don't have a bloody nose. I've looked in all of your facial orifices. You don't have trismus. Well, I don't say that to them. You can open and close your jaw.
right.
These are all the things. They don't meet necessarily any criteria. What I find most difficult about assault patients and why sometimes I'm a little lighter on the CT is because you ask them about loss of consciousness and
Right.
and they're like, yeah, I think I did.
It all
You know,
happened so
it so happens.
fast. I don't know.
I mean, I don't want to hang my hat just on LOC, but like if a patient's telling me, that they lost consciousness and they had facial trauma and, it's like, okay, fine. We can do the CT. But, again, following up in the next 24 to 48 hours with a specialist is great. And in my hospital, we have referrals for that, but some
Nice.
people may not. And then obtaining the imaging may be worth your efforts there. But again, every case is totally different. So many variables. Um, Minor fender benders where patients literally like it's just not possible for them to have a head bleed like from that car accident. Please don't CT them. But again, I'm not there with your patient. You are. And so you do what is best for your
Yeah,
patient.
we're not trying to make fun of people who have been, seriously or maybe even less seriously injured. But
Oh, yeah, it
but
happens.
that phrase comes up so much, like it all happened so fast. Like it's like, is somebody coaching you in the waiting room to say that
Yeah.
to the ED clinician? Because I hear that all the time, and it's like, okay, well, you remember everything literally to the millisecond before the ladder collapsed. You remember all of that, and then you remember to the millisecond being on the floor looking up at the shattered ladder around you, and it's like there's not enough time for you to have lost consciousness like in the middle. And if there was, it was like seconds long. And what's the significance of a seconds long amnesia? Whether was it amnesia or was it loss of consciousness? Like those are two different things. What's the significance? So not trying to make fun, but it does present a conundrum.
Sounds like a
Um,
moment at the craps table, temporarily lost consciousness while gambling on hard 12.
I had
So
this stack of chips in front of me, and I don't know. I must have passed out or something, and all of a sudden the chips were gone.
dude, listen to this story. I have to tell you, it's so brief, but I was watching someone play roulette because it's such a scam, and I was just
Oh
watching them pump
no.
money, and it hit like, I don't know, 8 reds in a row or something like that. And so after the fifth red, I could see that they were betting hard
Oh
on
my
black.
gosh.
They were like, it's going to hit black. And then it's red, seventh time. And then they were doubling 100, 200. They were
Oh my
doing, there's some
God.
theory that you just keep doubling. And so finally on the ninth red, they're like, $500 on black. You know what it was after that?
Hopefully.
Zero.
Oh
Which
no.
is terrible. And they ran out of money. So, and then after the zero was black. So unfortunate. but that's just how it works. Anyway,
That's
I
why I
just
play
had
blackjack. I'd rather grind away and win $5 after, 3
yes,
hours of hard work than lose my butt
feel
at
ya.
roulette. Okay, how about just general documentation stuff? Okay, so I love smart phrases. Okay, and I think that frankly, there are some big voices in the emergency medicine space who are, I think, over the top in their hatred for smart phrases. They're like, never use smart phrases. But honestly, like there's only so many ways you can describe how somebody's ankle looks, right? Or so many ways you can describe lung sounds or a neurologic exam. And eventually you have the best possible way to describe this exam or this condition or this discharge plan. You have a way. So why is it that you have to reinvent the wheel literally every time you do what may be a complicated exam, a complicated discharge plan? Why must you reinvent the wheel the entire time? I don't think you have to. I don't think it benefits the patient for you to have to make up a new set of phrasing for a complicated process every single time. So I am 100% in favor of using smart phrases and creating your own for many, many things. But I am also 100% in favor of you hard stopping every time you use one and go word for word to ensure they apply to this patient. I don't want to, accidentally put on there the patient ambulates with non-antalgic, non-ataxic gait, and they happen to have bilateral below knee amputations, for
Oopsie.
example, right? Or, their tonsils are 1+ bilaterally with no exudates if their tonsils are actually surgically absent, right? So just be very
That one's
careful.
really sucks.
Yeah, it's hard. Like I really have to ask a lot of times, like, do you even have tonsils anymore? Because sometimes you just don't know when you
Yeah.
look in there. Like, have they been taken out or what? But anyway, short story, smart phrases, I say use them because number one, they make repetitive tasks go by faster, and that's how we die a small death every day in emergency medicine is repetitive mind-numbing tasks every day over and over again until we quit or we're fired. So use smart phrases, but 100% review every one of them word for word to make sure they work for your patient.
Why'd you have to
Next,
wait? But why'd you have to say like quit or retire? Like,
what are the
can
other options? Dying on shift?
yeah, pretty much. That's how I want
I
to
mean,
go.
sadly enough,
I
right?
shouldn't
Yeah.
say that.
Not funny, Martha. Okay. Maybe
No, I think you said get fired. No, wait, you said you can either quit or get fired. You should be able to
okay. Oh,
retire or
retire then
die on
too.
shift. Those are your other
Okay.
options.
There
Or
are many possible options, I suppose.
or maybe you just get lost in the hospital ceiling and never to be found again.
I was trying to find the cafeteria, and 5 years later, I kind of stumble out from a closet somewhere, and like,
Exactly.
I'm still need the orange juice for my
Yeah.
patient.
Yes, please.
Okay, yeah, okay. There are many options to what could happen, but in the end, use smart phrases, review them very well. Next, if you use language services, and you should, if you're not a fluent speaker of the patient's preferred language, document the use in accordance to whatever policies you have. Even if certain hospitals are not super aggro on you using these things, if the interpreter has a name and has an ID number, document, in my opinion, document the name and ID number of those interpreters so it can be shown that, like, yes, you made an attempt as best you could to use language services. Any appropriate diagnoses you want to make sure you put in for their diagnoses, including, in my opinion, abnormal vital signs like elevated blood pressure. You want to note that you noted the elevated blood pressure and that they walk out of there with that diagnosis so they know that they had an elevated blood pressure. Abnormal diagnostics, so abnormal imaging, abnormal labs, those are diagnoses, even if you don't know the significance of those abnormalities. You can at least highlight to the patient, hey, something ain't right here. You got to follow up with somebody like I told you to.
Hmm.
Lastly, working in now to discharge planning. So, you know what? I think we'll just stop there. We'll let you kind of handle the discharge plan, Martha. But
Oh,
thoughts about general documentation in terms of smart phrases, language services. How many diagnoses maybe you use? Any thoughts there?
I think this is all great. what we talked about. I think whatever we talk about is great. But no, I mean there might be some other things we'd love for you to share those with us. Write it in and tell us. But what I want to share with you in regards to more discharge planning, of course, you can come and hear it live, is the odds and ends in EM talk. Been giving this for quite some time now. It is a crowd pleaser. One, because it is the last talk of the conference and everyone's really excited. Two, because these are things, they're literally odds and ends of things that you may not have thought about that I review. We go over things like discharge help, smart phrases. I actually give you some legal ease here on our smart phrases that I've created with some lawyers since I do some legal medicine stuff. And then we talk about follow-up plans and how to connect with patients, i.e. callbacks or your email address, so on and so forth. So what's really important is if you get lost in any of this, and some of this just seems like overwhelming, just see what someone else in your department does. You either love it or you hate it, and then compare it to somebody else and see how you can make it your own. And hopefully you can take a listen to this odds and ends lecture, and we'll put it at the end after our wrap up. And you can take a listen. It's about 20 minutes, maybe a little less, a little more, depending on what year we chose. And I think one last thing we didn't mention was actually writing the name of a doctor to follow up with, even if you hate that doctor, at least you've given a patient a name, because that's, a doctor, blah, 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 or a PA or an NP, blah, 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 that you can follow up with. And it's someone you highly recommend. So take a look and a listen at our show notes and our additional content today. And if you want to hear it in real time, you can come in November to hear the thing, and as well as dozens of other really wonderful talks.
Yeah, and we will have this discharge checklist for you. Like we actually, at an organization I'm with, we actually printed out little badge buddies with this checklist, so people can kind of put them in the back of their hospital badges, and they can have this next to them if they want to quickly review their own charting and make sure their charting is straight before they discharge a patient. So nice to have as quick reference all these things you want to have straight in your charting.
Yeah, so badge buddy, there's somebody I know from a previous job who had a badge buddy for when all the local bars closed and when which was Starbucks, were potentially 24 hours, which I thought was funny. However, I do not condone those things. All right, so it's time for our two-view trivia question answer. Our trivia question last month had to do with our great toxicology episode with Nancy Dumke, and thanks for your feedback on that episode. We had a blast doing that one. And the question was, what is the most common beta blocker in overdose? And what is the most common hypo or hyperglycemia in a beta blocker overdose? The answer is propranolol. It possesses a strong membrane stabilizing effect and how come I can never say this, Michael?
That's that show with the lady with the college student with the pretty hair, right? Lipophilicity. Wasn't that what I called that?
That's right. And Nancy talked about it so much, and she said it like a bunch of times. I still can't say the word, but basically very highly lipophilic. Okay. And it's also the beta blocker most likely to be seen in the cases of overdose, propranolol. And hypo or low blood sugar is the most common side effect, especially in children, and it can lead to nervous system symptoms.
Our word of this month is the aforementioned Julie, who also wrote us about transitioning to emergency medicine. Thanks for writing in, Julie. We'll be getting in touch with you about getting a discount to one of our courses to help you join the thug life with me and Martha in emergency medicine. Our two-part trivia question this month has to do with the Oropouche virus. I couldn't go another minute without saying that name again. What is the Oropouche virus named after, and in what year was it first discovered?
Email us your answer or any feedback or comments from this episode to 2viewcast@gmail.com. That's the number 2viewcast@gmail.com.
That is our show for today. More information on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course, that Bounce Backs medical and legal course that just came out, or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
We got 2 new courses in the works right now. I'm not going to tell you what they are until they're done, but you're going to love them. Well, I'll tell you, but I can't tell everybody else. Sorry.
I was going to say, like, why are you shutting me
I might
out?
tell
Come on.
Dave, but
I think Dave already knows.
he does.
Okay, right. Well, thank you for listening and attending this episode of The Two View. You can subscribe and rate us. Please rate us on Apple iTunes Podcasts, Google Podcasts, and Spotify. Search for Two View Emergency. That's the number 2 View Emergency, and it'll come right up. Ratings help us climb the charts with other clinicians, get some Two View goodness. If you like YouTube and want to see Martha's stunning highlights, my brand new button-down shirt I got from Kohl's, get you some Kohl's coupons, everybody. You can join the video blog, search for Center for Medical Education on YouTube, and you can catch the video version. Don't forget our website where you can go next level on any of our topics from any of our episodes, including so many guidelines. We have linked to about this episode and other previous episodes. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
Thank you again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today at The Two View. Have a good day and a great shift. Toodaloo.
I got to get a new charger now.
I want to just talk about a couple of things. The talk is called Odds and Ends because most of what we do is odd, and in the end, we all want to leave. So, this is actual discharge paperwork from someone here in Las Vegas. Never drink like that again. Probably not the best thing to put in the chart, but certainly could be what you're thinking. I always want to remind people the top 10 reasons why people go to the emergency department. As a clinician, you're trying to think to yourself, how am I going to put all this information together? How am I going to apply this when I go back? There's so much to know. But if you know these 10 things, 75% of the time, you're going to have a great diagnosis, workup, and plan. Maybe not all in that order, but you'll get there. The number one reason people go to the hospital, in general, the emergency department or urgent care, is abdominal pain. If you know abdominal pain like the back of your hand, you will be successful at treating it. The same with chest pain, fever, cough, headache, back pain, just random pain, any kind of pain, dyspnea or shortness of breath, accidental trauma, and vomiting. You also have to be an expert at writing a work note. As I mentioned, we do have the top leading causes of why people go to the hospital, but even more so, you should pay attention to the top 10 causes of death. If you know what's going to kill people, you can better prepare your patient and yourself for taking care of them. Heart disease is the number one killer in our country right now. Think about all the things that lead to heart disease. Cancer is another number one killer. Accidents, chronic lower respiratory diseases, COPD and emphysema, stroke, Alzheimer's disease, diabetes, flu and pneumonia still killing people, top 10 causes of death in the US. Nephritis and nephrosis killing people. And up there in our top 10 is suicide. If you're prepared for these 10 things, you're going to do well. There are some deadly days in the United States. Ken Milne shared this with me about a year ago. Talks about every day of the week what might happen. I don't like working Mondays in the ER, ever. I promised myself once I had been in this business for over 20 years that I would never work a Monday again. It's just not worth it for me. It's too crazy, it's too busy. Statistically, it's one of the highest days of patients that arrive in the emergency department. So Mondays aren't for me anymore. I'm going to take my chances and go to one of the other days that maybe have a higher risk of firearm or car crash day, because those are the ones where I don't feel as frustrated for myself, but I do feel frustrated for the patients. But it is interesting to look at some of these statistics. Also interesting to look at who is our high-risk patient. If you know who is at high risk, you're going to be less likely to make a mistake with them. The highest rate of readmission in 30 days after discharge are the following things: circulatory system diseases, respiratory diseases, infections, GI diseases, mental health, and accidental injuries. If you know that these patients are more likely to bounce back, then maybe you'd be more likely to intervene earlier. Don't let them go without some specific thing that they need. And we're going to go through those specific things that the top 10 list needs. So 30-day readmission is the most high in patients who are billed with Medicare, followed by those with Medicaid, uninsured patients, And then finally, those with, believe it or not, private insurance. Well, of course, they're probably going to be at the bottom of the list because they have private insurance and they're probably going to get seen and get preventative care. Other high-risk populations, as Gooch would like to remind us, anytime we combine all these things together, it's going to be a really difficult patient. They're going to have lots of diseases, and the polypharmacy can make it really difficult for you to manage them. They're high risk. They forget when they take their medication. They don't know what medication they're on. Anyone who's diagnosed with more than 6 conditions, which, believe it or not, is so frequent. You think, oh, well, this person's just coming in because they have chest pain, and that's their diagnosis. No. They have diabetes. They have a history of cancer. They have hypertension, and a whole laundry list of other things, probably anxiety, depression, and PTSD. So remember that if these patients have multiple conditions, they're at high risk. Any prior hospitalization in the last 12 months, and of course we still have health disparities that exist that have people who are at high risk. Before they go, back when Greg Henry used to lecture, one of my favorite teachers ever in the history of teachers, he would always remind me, did you do a final assessment? Did you go in and say, I'm so-and-so, it was nice to take care of you? Or did you just push discharge patient and never go in there and really talk to the patient? It happens more than you think, than you realize. It's like you just don't want to see that patient one more time. You feel like you already explained it, you were just waiting for one more test. Okay, as soon as that urinalysis comes back, you can get out of here. Tell the nurse, okay, just discharge them. No, go back in there and tell the patient, your urinalysis didn't show any findings. It's going to help you in the long run. Also, vital signs. Diane reminds us vital signs are vital. Did they improve? Document that they did. What is abnormal? What's not expected here? What might you have overlooked? And then, of course, what did you find? Very important pearl is that if you have an incidental finding, you need to print it off and highlight that on the paper. Say, here, we found this, explain to them, have that whole long discussion about what it may or may not mean. But you're the emergency department clinician today. You're not going to emergently work this up, but it's something you should be concerned about. I tell the story at every single course that an emergency room doctor saved my life. Not for the reasons that you may have thought. It wasn't really an emergency. I had been going to the emergency department to work, and a couple of shifts later, I had a really, really severe headache. The short story was I was getting worked up for a subarachnoid. I had just done actually a really hard CrossFit workout, and I was worried that I blew my brain up. Turns out I was just really out of shape. So I got the CT angiogram of the head and the neck to rule out anything really bad, including a vertebral artery dissection. And I was about to leave. And the physician, the emergency physician, who I wasn't that close with at the time, ran into the room and said, no, don't go yet. I want to review your incidental findings with you. I said, incidental findings? No, you said everything was fine. Well, we noticed a suspicious mass in your neck. It's very small. And after I heard the word suspicious mass, I pretty much lost my mind. But he stayed an extra amount of time to talk to me about it. And at the time, as a junior clinician, I was very young, he was telling me about what we do with incidental findings. He said, you need to go get an ultrasound. Go get an ultrasound of this thing. So I did, and I followed it for 10 years. And when my giant Hürthle cell tumor became the size of my fist, I called him up and said, thank you for telling me, because I would have never treated this. It was growing in a strange direction, and I would have never known if it wasn't there and I hadn't followed it. So emergency room clinicians can save your life for other reasons. Tell people about their incidental findings and have them follow up. Also, we're talking about following up. Do they even have a resource? When you give someone a resource, say, go see Dr. Wong. He's amazing. Like, I really like Dr. Wong. Even if Dr. Wong is like a giant dick, like, just give them a name. You know, promote your business. And when you promote your colleagues, they will give better care to your patients. I'll never forget telling a physician, when I was at the bed as a bedside nurse, Dr. Friedman, I was in the room and we had to do an elective intubation for an angioedema. And the patient was really in distress, but it was more of it was a urgent intubation, but of course it was still emergent. So Dr. Friedman came in and she was very nervous, looking all around, and the patient's really nervous. And all I did was put my hand on the patient and say, it's going to be okay. You got Dr. Friedman. Meanwhile, everyone's looking at me like, everybody hates Dr. Friedman. Dr. Friedman goes and intubates this patient, does an amazing job, gets past that terrible tongue. She looked at me when we went out of the room and said, I didn't know that you liked me. And I said, I don't. But I know that the patient feels safe now. She laughed and I said, no, I really do appreciate what you do here. And we may not get along with our personalities, but you're a wonderful doctor. And from then on, Dr. Friedman and I have been best friends. We write each other. We're not anywhere near each other, but she's one of my favorite people. Make friends with that person that nobody likes. You'll be surprised. Also, did you set up an appointment? We used to do this all the time for patients when we lived in rural medicine. Hey, doc, I got your patient here. Can they follow up with you? I want to make a quick appointment. So depending on where you work and what your shop is like, you can do this for patients. You may not always be able to do it, but why not try if you can? Just takes a minute or two. Always answer questions. Say, do you have any questions? It's not, do you have any questions? Walking out of the room. The National Patient Safety Foundation. Now, I know Mike Sharma doesn't particularly like this because he doesn't like to repeat things over and over and over again to his patients. He doesn't like to insult patients. So if he were still here, he would say this isn't really his thing, but it might be your thing because most patients, almost half of our patients are unable to describe the reason why they were hospitalized. 54% could not recall instructions and follow-up appointments, even though they were printed out for them. You tell them you were here for chest pain. We're not quite sure what it was, but these are the things you need to do, and we list it all out. And they go, so am I having a heart attack, or like, is my EKG normal, or like, what's going on? Even though you already explained that. So these teach-back techniques I really like. After I go through everything, first I say, do you have any questions? And then they say, no, of course not. And then I go, well, can you tell me about your main problem and how you're gonna take care of that? Well, I was gonna ask that. So if you explore further, you realize that people are nervous. They're either excited that they get to go home and they've been there 8 hours, 9 hours, they're ready to go, or they might have a learning disability, or they might just not know what to ask. These are the required things that you need to put on your paperwork. You can see the list here, obviously your name, a physician's name if they worked with you, certainly your diagnosis, any potential complications, medications and side effects, follow-up, specific timelines. If you found an incidental finding, follow up with your doctor within the next month or two. And then, of course, this document of receipt of the patient's signature. People always ask me, what if they don't sign the paperwork? You can say that you explained the paperwork, but the patient didn't sign because they forgot, or you went into the room and they took all the paperwork with them. So just maybe put a little note in there about what happened. Because otherwise they're going to say, you never told me this. Never told me that. So I said we're going to quickly go through all these top 10 causes of reasons why people come to the emergency department, and the things that should light off in your head, those red flag things that you need to pay attention to or document. We're trying to summarize everything you've learned in the last couple of days in one slide per complaint. So abdominal pain, since we said it's a majority of ED visits, remember that 25% of the time it's going to be inconclusive and you're not going to have an answer for somebody. So make sure that you review, is there anything abnormal in those labs or images? Discuss with the patient, and this is the key. You go in and you put your hands back on the belly. Okay? Reevaluated the patient, abdomen soft, non-tender, no guarding. Patient actively eating, going to the bathroom. Tolerating PO fluids, non-distressed, eager to leave. I love putting this in the chart. When can I get out of here? I feel great. Chest pain. A lot of these diagnoses of chest pain unspecified could be a lot of things, right? But we know you're not having a heart attack right now. Consider the age, the presentation, and risk factors when you're discharging these patients. Even though they might be low-risk patients, you want to say, if you continue to have chest pain, we'd really like you to come back. Review that EKG again. Get a repeat if you just don't feel comfortable. And then you can document any of your particular scoring system or risk factors that you used in your chart that we talked about. And then as Scott had mentioned, talk about briefly that, you thought about this, but you don't need to go into a big long sentence as to why you did or did not do testing. But you could say unlikely that this was a PE, unlikely MI. Because if you were called into court to dispute a chart, you could say, well, it was unlikely to be a PE because I know X, Y, and Z about PE and they didn't have it. So if you're able to define why it's not a PE is, then you should be okay. Don't need to write a whole novel. Remember to always document the vital signs and plan for follow-up. Back pain, large portion of our patients will have back pain. If you're on the planet for at least 30 years, as we said, you're going to probably have back pain at some point now. Remember that don't just say, you have back pain, it's probably musculoskeletal, and you'll get better, you big baby, right? Well, back pain sucks. It's really painful, and there are actually some really good guided therapies for back pain. That includes exercising, acupuncture, stretching, not laying flat all day long. These minor things to you, your patient doesn't know. You have the privilege of knowing this information, and as redundant and repetitive as it is for every patient that comes in with abdominal pain, chest pain, and back pain, you still need to tell them these things and put it in your paperwork. The key here are the red flags. I always document these. Did I ask about fever? Did I ask about saddle anesthesia, incontinence, retention, which we know is even worse, neck or headache pain, chest pain, so on and so forth. So remember that if you didn't ask these questions, you might want to reevaluate the patient and ask. I also like to say that they have sensation, motor, and other movements. Patient up to the bathroom without assistance. Patient voided, had a normal BM in the department. Patient has improved pain and mobility as evidenced by, like they walked, even with a walker, they walked well with a walker unassisted. And then you can say there's no obvious signs of cauda or spinal epidural abscess. And you can put extra documentation like, they didn't have a fever, or I had specific reason why not to think this. Short, sweet, you're good. We know cough is another reason why people come to the ER. You're gonna tell your patient, this is not going away tomorrow. We talked about this in the cold and flu talk. Smokers, it may take longer. You could say, listen, when you feel like smoking again, you're probably on the mend, right? But can I recommend that you don't smoke anymore? Strict return precautions for people who have a cough. Fever, vomiting, and shortness of breath, not good. Also, remind them of those over-the-counter medications that can be problematic, or maybe ones that might help them. The honey, the rest, the fluids. Documenting the key things like, other serious pathology was ruled out, not suspicious for, again, pneumonia or other severe process. I always like to say that the patient appears non-toxic, and you can further define that by using one of the examples I put in this other one, right? Eating, drinking, laughing, whatever. Had a nice conversation. Anything that you think sounds kind of ridiculous, if it's what a patient is doing, it just shows that they're able to move and groove, which is important to me if there's a problem in the future. Asthma or COPD, we know these are problems. I like my respiratory therapist to come and help with the discharge. If they need a new inhaler or a spacer, I'm not saying this like it's not my job. I just literally don't have time to do these discharges. It's not that I don't want to or I can't. It's just that the respiratory therapist, if they're not currently intubating someone, can come over and do this. Why not? Come on, join the team. Document the saturation, the vital signs, and did they improve? Gave 2 albuterol nebulizers. I re-listened to the lungs. The patient appears non-toxic, speaking in full sentences, eager to go home. And then you can bill for documenting smoking cessation. Now, I don't work off commission. It's not my thing. But for the hospitals that do, if you're doing it, you might as well get paid for it. Pediatric fever, obviously we talked about this being so important that you review the physical exam with the parent and then reevaluate and do the physical exam again. Complete that documentation. Review Motrin and Tylenol regimens with parents. Giving them a generic handout sometimes can be useful, but we all know that obesity is a problem and that we need to correctly dose kids. So just saying take 2 teaspoons of Motrin, it's not going to be useful. Even the box is incorrect. So I give them a prescription, and usually their insurance company will pay for it. Not to mention a box of liquid Tylenol can be anywhere between $10 and $15. It's very expensive. Also letting in the chart, making sure that you have documented that the child looks well, eating, drinking, vital signs, breastfeeding, etc. What about patients who have lacerations? Again, we're trying to bring every diagnosis we talked about into the conversation. I have this SMART phrase. I love it. I use it all the time. And for Epic, if you put a little asterisk in each of these, I can just click right through and write it in. If anybody that has Epic knows what I'm talking about. You can read more about smart phrases on your own time, but this is one that I have in my box. Today, you had a laceration to your right finger. We placed 3 sutures. They need to be removed in 7 to 10 days. You may do this at your doctor's office or here if necessary. We updated your tetanus shot today. If you smoke, it will delay the healing of your wound and increase your risk for infection. Pretty straightforward, right? Make sure you document in your chart if you did have a laceration that you controlled the bleeding, neurovascularly intact before and after splint application. If I put a finger splint on there, you can charge and bill for that too, but also it's just good practice, right? If there's any tendon involvement, you explored the wound, full range of motion. In regards to fractures and splints, speak about most fractures. Talk to the orthopedic about them if you think they're going to need anything in the future, anything at all. I think it's always important, again, to get those people on your team and give a good referral. Remember, tell patients they shouldn't get the splint wet. Strict return precautions were pain or numbness. That's the key stuff you need to put in the chart. And again, neurovascularly intact. You've given them sling for comfort. You've addressed pain control because the core measure for any broken bone within the first hour is to give something for pain. And you get dinged if you don't do that. In regards to inconclusive diagnoses, chest pain unspecified, again, smart phrase that I have here. Today, we completed a workup for chest pain. Sometimes we don't always find out the cause of your symptom in one ER visit. The findings of your exam today on your blood work, blah, 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 feel that you can be discharged home. Now, I've had an MD-JD look at a lot of these smart phrases because, I wanted to make sure that they were clean, cut, concise, and safe. And I just forgot to mention that that is something that I've done, so if you want to steal them, go ahead. They are going to be fine. I'm not going to read the rest of this to you, but again, read the attached instructions because you're giving them additional information about chest pain here. Here's my smart phrase for Motrin and Tylenol. I love this one. Of course, this one can be a little bit different depending on what you like to prescribe because we know the pain ceiling for Motrin or ibuprofen or other NSAIDs can potentially be the 400 milligram dose. And so, I also put evidence, why didn't I get an opioid? Why didn't I get something stronger? Well, the evidence really doesn't support it, but if you take these two together, you might actually have decreased pain, more likely to have decreased pain. How about that narcotic smart phrase when you do prescribe it? We've given you narcotic pain medicine. Please try these medicines first before you take the opioid. It can be addicting, cause nausea, you can't drive, you shouldn't drink alcohol, can cause severe constipation. So if you choose to take this medication, please add a stool softener. And I give them a name, right? You have the privilege of going to the store and be like, I know that I'm going to pick Colace versus, something else that has some fancy C name. Tell them, get Colace. Why not? What about those chronic pain people that come in and they're like, well, I know I was here yesterday, but I'm already out. So you can have this documentation. And I really like this one. I got this from a physician at one of my very first jobs. We shared this one. It got passed around the department. This patient has chronic pain. We have spoken about multiple previous evaluations and workups. I explained at length that I would be ready to address their complaints appropriately. I stressed the importance of safe care and did not disregard or dismiss their complaints, but explained why I thought I was concerned about narcotic dependence, misuse, or potential for abuse. I explained that I provided a stabilizing exam and will pursue the least invasive course, so on and so forth, add whatever else you like. And then you told them about your department's pain policy, which you all have a policy on treating pain. You say, I am not allowed. I don't say the word supposed to. I am not going to. I am not allowed. It is not our policy to prescribe you more than 10 pills or 15 pills. Now, of course, you have the ability to prescribe. You do have an independent license, but your department has a policy so that it can, when a patient says, well, you only gave me 10 pills, well, our department's policy is to only give 2 to 3 days of opioid pain management due to the risk, blah, 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 blah. Important, lastly, your signature. Dear whoever, your diagnosis today is chest pain. Generally, you should start to feel better in a couple of days. If you don't improve within this amount of days, follow up with the specialist provided. And then, of course, in all bold and caps, if you are worse, return to the ER. Patients are going to come whether you want them to come or not. It is not your job to say, look, just really don't use the ER unless it's an emergency. Who cares? You have job security. Let them all come. You know, you can't carry the world on your shoulders. Just see who you can see. And, you know, that homeless patient or that patient that comes every day, they're still going to come back whether you tell them, you know, we hate you or not. They're going to keep coming back. So be nice and give them a sandwich. At the end, I always put, please read the attached instructions, and then you can highlight things with your little highlighter. I always have like a nice little color combination in my pocket. And controversial, I know, but I will tell you of the thousands, literally thousands of patients I've seen, maybe one every month emails me. And you know what that email says? Thank you so much for taking care of me. Or I went and followed up for my wrist fracture, and you're not going to believe it. You know, I actually didn't need surgery, just like you said, even though I argued with you for a really long time about it, but thanks for the splint. And you know what? Motrin actually worked for pain. I didn't even take the narcotic that you prescribed. I really very rarely ever get anything troublesome or will put me in a dangerous situation. And you all can have my email. You know, I may not respond to you today because I am going back to the tables to win my money back. But I always say, do not hesitate to contact me with questions. If it's a life-threatening emergency, you're not responsible for that. So I find no reason not to give your email. I think it's good practice, and I only get accolades, which I then forward on to my boss, hoping for a raise. Additional stuff that always goes in every single one of my charts, if the hospital didn't already put it in there. Think about these big things that send people to the hospital. You're the change that we want to see in the world, right? If you smoke, please stop. Please see a dentist at least twice a year. You don't have a PCP, here's our list of primary care people. Other things to consider, put those images on a disc, okay? So we found a very small potential aneurysm in the left ICA. It's really small, it's less than 2 millimeters, but you're gonna need a repeat MRI or CT in the future. Let's give you that. Print out copies of lab testing or radiology dictation. I always print out the thing that says no fracture, dislocation, and the rest of the x-ray is normal. Phone number and address of your facility. Homeless shelters, if you need those, addiction specialist, suicide, mental health referrals. It's a joint commission suggestion. And then, of course, chronic pain management for people who may need it. And as I mentioned, primary care and dental resources worksheet. If the pharmacy is closed and you are allowed to do a pill in a pocket, sure, I do that. I might give you some double bonus points, or their first dose of their antibiotic, why not? So people always ask this question, well, let's say I want to give 7 days of this antibiotic. And now when I do my prescription, I got to take away one pill. No, just write them the same prescription, but give them their first dose. It's a very nice thing to do. Don't need to get into, don't take this last pill. Just give them the normal amount that you would give them and start their dose that night. Consider dispensing that eye or ear drop that you used, right? So you use like 2 drops in their ear and then throw away the bottle. No, just give it to them. A lot of nurses will say, no, we're not allowed to do that. Well, in reality, you are if you're prescribing for it. It costs the hospital money, but you already used it and you're just going to throw it away. Again, check with your institution to make sure that that's okay, but I do it. Finally, as I mentioned, the late, great Jim Roberts here winning his ACEP award that Diane had won, and Ken and Rick, they all had won this award. It's been a year since Jim has died, and for those of you that don't know, Jim and I, he was a physician, an emergency physician, one of the first in the country, wrote a really wonderful book called Roberts and Hedges, Clinical Procedures in Emergency Medicine. It's a fantastic procedural book. Diane and I are working on the 8th edition. Even though he is not here, he used to do this course. He did it for about 40 years, all the courses. So he is very much missed. And he would always say, giving that name of that specialist and really saying that your colleague was great, even if you hate them, is one of the best things you can do. It really changes the milieu of your department and your relationships with the people you work with. So I like to carry on that advice. Finally, calling your patients back has been proven to improve satisfaction and quality. I used to go in all the time starting out in my career. I'd get there 10 minutes early. I'd call 2 or 3 patients. How you doing? Hey. They'd answer the phone like, is who? Yeah. Thanks for calling. Yeah, I feel great. Thanks for everything that you did. Or, oh, you know, I ended up having to go back because the splint fell off. Whatever. I mean, I learned so much from following up on these patients. It really improved my quality of care and theirs. Final thoughts. Vital signs are vital. Work notes are cherished. There is never an excuse to be mean. Following up with patients is not illegal or dangerous. It can help your practice. Keep track of your interesting cases. Make notes in your book that you've been given. And then come to one of our other awesome courses. The closing remarks here, you can find all of our information on ccme.org. The Slido questions, if you want all the questions, we will email them to you. In the past, we've had 1 or 2 people want those, so sure. Hopefully we've answered them all in real time and you won't need to. The live stream will be available for the next couple days as you're flying home and gambling. You can check that out on ccmelive.org. And you can purchase the self-study course if you go to our website for a discount. And you can also get a copy of your CME certificate. The only way that you get a copy of your CME certificate is to do the survey. Just give us information that will help us do better, or tell us something that you liked, and we would love to improve our practice as well. Thank you so much for coming. Safe travels home. Bye for now.